Hello, everyone. Welcome back to the Facets curriculum video series. My name is Thomas Wharton. I'm one of the chief residents here at Vanderbilt University Medical Center and joined today by Dr. Maru Duggan, who is the geriatrics program director and an inpatient hospitalist on the ACE unit here at Vanderbilt. And today we're going to be talking about a topic that I think sometimes gets overlooked, and especially is one of the new part of the 5Ms. It's actually multi-complexity. So Dr. Duggan, can you share your thoughts on kind of this evolving kind of facet of geriatrics and part of the kind of assessment that we want to take into account when we're seeing our patients?
Yeah, absolutely. So geriatric patients, older adults, can often be very complex, have a lot of illnesses going on, be on a lot of medications, and it can be really challenging when you take the approach of going by each single disease and addressing each single disease without the context, holistic context of the whole patient. So multi-complexity really helps you take into account not only the multimorbidity of patients, over half of older adults have more than 3 chronic medical problems. So not only multimorbidity, but also things like psychosocial situations, living situations, what support do they have, as well as prognosis when our management changes depending on what the prognosis of a patient is. And, evidence-based medicine is fantastic. Oftentimes, it's challenging to apply those evidence-based medical guidelines to older, complex adults, right? If you were to take single disease recommendations and apply each of those individually to patients,
Hmm.
oftentimes those care plans are very complex. Many medications for one disease will cause problems for another disease. Many
Absolutely.
medications for two diseases will, cause side effects, right? And so it can be really challenging to apply these guidelines in a siloed approach to the older adult, right? And so we acknowledge that sometimes we won't, treat a patient with maybe a drug that's a grade A recommendation for a certain condition because it
Hmm.
may cause problems with other conditions. It may not be feasible or practical for patients to implement, right? And patients may not live long enough to really benefit from that intervention. And oftentimes these treatment plans aren't necessarily in accordance with what matters to the patient. So multi-complexity really is a holistic approach that takes into account all of these factors. And so this 5M framework can be really helpful for us as we think through an approach to managing complex older adults.
Absolutely. That's really helpful. And I think, at times, new learners to the field of geriatrics might be a little overwhelmed with how many different things are going on with a particular patient. Um, what would you recommend in kind of assessing for multi-complexity in some of these patients?
Yeah, that's a great question. So it can be really challenging especially in the inpatient setting where you're dealing with fires. You're putting out fires left and right, right? These acute medical problems. And sometimes you don't always have time to dig into all the comorbid conditions, sort of taking this holistic approach to patients. But I think in the long run, it will really help inform your medical management of a patient and is really essential. So, one way we do this is through comprehensive geriatric assessment, right? So, this is an approach that really helps us inform the management of multi complexity, and comprehensive geriatric assessment's been studied and it's shown to prevent functional decline and improve mortality among older adults. It's an approach that involves rapid screeners for various conditions. And then, depending on what those screening tests show, you can delve deeper into an area. Comprehensive geriatric assessment can take quite a long time, and you don't always have the luxury of time in the inpatient setting. So that's
Exactly.
where the 5Ms approach can be really helpful to doing a targeted geriatric assessment, right? So those 5 M's. Medications, right? So a med rec is super important, and starting with the medication reconciliation can help you know what those core comorbid conditions are, right? So you're kind of getting a 2-for-1. You're looking at the medicines and you're looking at multimorbidity. So medications, mind, right? So screening for delirium, especially in the inpatient setting. In the outpatient setting, we think about dementia, depression as more common conditions that we'll see in the outpatient setting. So medications, mind, mobility, along with mobility, I think of functional status. So
Definitely.
what's the state of those basic activities of daily living, those instrumental activities of daily living, and how is the mobility doing at baseline, right? That's super, super important. And then the what matters most, right? So what matters most, kind of the keystone approach to managing older adults, in that we have to know what's important to them so we can know if our recommendations are aligned with what matters. So there's some key aspects of geriatric assessment, and I think that 5M approach, there's also the 4M approach, which leaves out multi-complexity, sort of 2 frameworks. But I think either of those frameworks can be really helpful to kind of boil down geriatric assessment, which can be a much larger um, something you embark upon with a patient, and helps us target into certain kind of areas within geriatric assessment.
Definitely. And if there's a patient who we think, has this multi-complexity and all of these different layers, how would you go about documenting this in the chart? Or is it something that you just relay to your attending or peers from an inpatient to outpatient setting? How would we go about letting other providers know that this patient is fairly multi-complex?
Yeah, I think you can name it, right? You can say one of
Mm,
the problems is multi-complexity, and I think sort of uh, listing out what are those specifics about multi-complexity that you're worried about, right? So is it functional disability? Is
oh,
it delirium with concern for post-hospital cognitive impairment in a situation where maybe there's no caregiver, maybe there's limited social support, and we're worried about an individual managing at home after delirium, managing their medications, driving, things that require cognitive sort of problems. So I think at discharge, right, as we plan towards discharge, it's important to ask and document these things and to take them into account. A lot of geriatrics is kind of common sense, right? So we don't get stuck in the weeds of, it's important to manage diseases as optimally as we can, but we take a step back, see the forest for the trees, and come up with a practical plan that's going to take into account how someone's functioning, right? In the home setting, what changes have there been in the hospitalization, and how can we best connect them to community resources if they're going home that are going to help them thrive as much as possible.
definitely. I like that framework as well, as seeing the forest through the trees, especially in these patients with so many different complex issues, as you were alluding to, and really getting the person as a whole kind of under wraps before they are discharged from the hospital, in hopes that their outpatient geriatrician or primary care provider will hopefully be able to kind of pick up all the good progress that we've left off. And in thinking about multi-complexity in the hospital, especially in the ACE unit, Dr. Duggan, are there any other things or any other pearls that you have for our learners, just to kind of keep an eye out and make sure that some of these things don't fall through the cracks?
Yeah, absolutely. So, I think if you do have the luxury of time, it's really beneficial for patients. You're doing them a great service. You're also helping the primary care physician if you can do really a comprehensive geriatric assessment. So I think knowing those parts, which include looking at functional status, looking at screening for various geriatric syndromes, thinking deeply and broadly about that psychosocial situation, and then thinking about what's important to the patient, what their goals are for the time they have left. That can be very valuable for the patient, help steer the treatment plan in the right direction, that can then help the primary care physician as you hand off the patient. So I think it's great to know all those pieces of geriatric assessment. And if you don't have the luxury of time, picking and choosing what's going to be most pertinent.
Definitely. That's really helpful and something I'll continue to think about moving forward in my own practice. Well, this has been a fantastic session on multicomplexity, and I look forward to seeing you again, Dr. Duggan, when we talk about further aspects of the FACET curriculum in video format.
Thanks, Thomas. This was great. Fun to be with you.
Bye, everyone.